outcomes of heart failure, and we have been sort of struggling, or we have been trying to get better and better treatments for improving the symptoms, improving the outcomes of heart failure. And so this is the journey. So we had the various trials starting with hydralazine, angiotensin convertase inhibitor or ACE inhibitors, ARBs, beta blockers, and then we have been having these important trials till we came to couple of drugs which we will talk about, and that was a big step forward. And that was the paradigm heart failure trial. The study design of this was after the running period, just to check the tolerability. It was a comparison of enalapril 10 milligram twice a day versus ARNI or sacubitril valsartan combination, which at that time was HZ 696. So to the maximum tolerated dose. These patients were basically heart failure with ejection fraction of less than 40%, and INVICH class of 4. And the primary endpoint was cardiovascular mortality or first hospitalization for heart failure. So this is on top of the standard of care. That means patients who were already on standard of care treatment. So these were the key inclusion criteria, and that included stable heart failure with more than 4 weeks of stable treatment with ACE inhibitor, ARB, and a beta blocker, the elevated BNP levels, and aldosterone antagonist was also considered as a standard of care treatment. The exclusion criteria importantly included patients who had eGFR of less than 30, serum potassium, which was higher at the time of inclusion, and acute decompensated stage of heart failure, and any other severe pulmonary disease. So this was one of the largest mortality morbidity trial in patients with heart failure with reduced ejection fraction. And what did we find? We found that the most important endpoint, which is cardiovascular mortality, was reduced by about 20%. The heart failure hospitalization was reduced by 20%. The all-cause mortality was reduced by 16%. The heart failure related deaths were reduced by 21%. And sudden death, which is one of the most important things to prevent. And this is the magnitude of treatment benefit in patients with or without ICD. So you can see here that even the sudden death was prevented. If you look at the magnitude of benefit, this is just to put the things in perspective, that the relative risk reduction in the heart failure hospitalization and in the relative risk reduction in mortality in the previous trial is to the extent of 17 to 30% in mortality and 40% in terms of the heart failure hospitalization. We will not talk about the hydralazine because that specifically applies to kind of black population. But you can see that ARNI, which is after all this reduction, that means it is not ARNI as an isolated drug, but over and above the drugs which have already been able to reduce this mortality and heart failure hospitalization, ARNI is able to produce an additional mortality reduction of 21% and heart failure reduction of hospitalization reduction of 21%. So we also know that the other important thing is the symptomatic benefit. And here you can see the NYHA class change after sacubitril valsartan initiation or the ARNI initiation. So after 30 days of treatment with ARNI, there was a significant improvement in the NYHA class with 34.3% patients who experienced improvement. And before starting this, the 8.6% patients were in NYHA class 1, but after treatment, as you can see here, that it was 32.4% were in NYHA class 1. If you look at the subgroup analysis, that means if you look at the various pre-decided subgroups, then you can see the age, the ejection fraction, the eGFR, the starting systolic blood pressure more than or less than 120, or whatever was the starting NT-proBNP. If you look at all the spectrum, then the ARNI was better in all these subsets. So irrespective of any of these subsets, there was a superiority of ARNI over NLM. So this was a clear-cut indication. If you look at the population, because we also want to know if these results are applicable only to the Western population, or are they applicable to our population also. So if you look at the primary composite outcome, the cardiovascular mortality, and so if you look at the South Asian population results, you will find that there is a significant benefit. But the confidence intervals are somewhat wider than the overall, and that is because of the subset analysis, which has a relatively fewer numbers. So, but if you look at the cardiovascular mortality, all-cause mortality, heart failure hospitalization, then in the South Asian and Southeast Asian population also, there was a significant benefit. This is a very important concept to understand, that there is nothing like stable heart failure, or for that matter, now we know not even a stable coronary artery disease. But 20% of the stable patient, so-called stable patient in paradigm heart failure, had a primary event, and 17% died during the course of the trial. So of the so-called stable patient who experienced primary event, the death preceded the heart failure hospitalization in 51%. So it is not as if you would be able to predict, because the first event that occurred was death. And 60% of these were sudden cardiac deaths. So in these so-called stable patients also, there were not like the patient gradually deteriorating, giving you multiple warnings, but it was the first event itself was like a sudden death. And therefore, there is what we understand now is that there is nothing like stable heart failure. One day, this stable heart failure is going to land up into an event. And if it is going to land up into a serious event, like, of course, like death or sudden death, then we want to prevent that. And therefore, ARNI should be started as early as possible in the management. So this is the 2022 AHA-ACC guideline for management of heart failure, which includes in the class 1A category, that patients with HFrEF in NYHA class 2 to 3, the use of ARNI is recommended to reduce morbidity and mortality. Now, only when ARNI is not feasible, then you can use other agents in patients with previous or current symptoms of chronic who are intolerant to ACE inhibitor because of cough or angioedema. And when the use of ARNI is not possible, then ARB can be used. So this is very important, that now ARNI is the drug of choice. It is only when it is not possible that the ARNI should be replaced by an ACE inhibitor or ARB. Now, is the de novo heart failure separate or different from the acute decompensation in a chronic heart failure? So you can see the phenotypes in the decompensated heart failure. Those patients are relatively older population who have a known history of an underlying heart disease or heart failure. They have multiple comorbidities like diabetes, ischemic heart disease, COPD, previous stroke. They might have undergone previous interventions or bypass surgery. They usually are triggered by events like withdrawal of medication or resistance to medication, other precipitating factors like infections, cardiovascular complications, and certain drugs like alcohol and digitals. So clinical presentation is, of course, more like congestive failure. The main pathophysiology is the pulmonary and systemic vascular congestion. Now, if you look at the de novo heart failure, obviously they don't have a previous history of heart failure. They have less incidence of comorbidities. The trigger events are usually either ischemic or a valvular incompetence or inflammatory or toxic, and they present with acute pulmonary edema. And the main pathophysiology is the systolic dysfunction causing acute hemodynamic consequence. Now, how early can we start in this acute decompensated heart failure? Whether we should start it at follow-up, whether we should start during discharge. So the answer to this somewhat comes from the Pioneer Heart Failure trial. This was for patients with hospitalized with ADHF with ejection fraction of less than 40%. That's what we define as the HFrEF. While the patients were being stabilized, that means when the patients had a systolic blood pressure of more than 100 in the previous 6 hours, there was no symptomatic hypertension, there was no change in IV diuretics or no IV inotropes or vasodilators. These patients were then sort of randomized to enalapril and ARNI. And this was the in-hospital initiation, and various other parameters like tolerability, the levels of NT-proBNP, and of course the clinical outcomes was studied. Now, what you can see here, NT-proBNP is a very good surrogate marker of outcomes in heart failure. And so therefore, a reduction in NT-proBNP tells us the prognosis of the patient to a large extent. Now, if you look at the change in NT-proBNP, you find that the ARNI reduces the NT-proBNP much better. But more importantly, also you can see that this effect starts quite early. So if you look at the end of 1 week itself, there is a significant difference in the level of NT-proBNP. So there is a better NT-proBNP reduction, and that starts very early. Now, if you look at the cardiovascular mortality or HHF or hospitalization for heart failure, here again, you will find that there is a definite benefit. These curves separate from quite early period, and they keep on diverging. So therefore, there is a very continued benefit. Now, if you look at the pre-specified subgroup analysis, whether it is a de novo heart failure, so the blue bars are the ARNI, the red bars are the enalapril. So you will find that the change in NT-proBNP, all the blue bars are sort of more than the red bars. So in all these situations, that means whether it is a de novo, whether it is chronic HF which is worsened, whether the patient is having ACE inhibitor or ARB, or he is not having previous treatment with ACE inhibitor ARB. So in all these subset, the ARNI is able to reduce NT-proBNP in a more superior way. If you look at the outcomes in patients without prior ACE inhibitor ARB exposure, then you will find that again, the outcomes in terms of NT-proBNP are definitely far superior as compared to enalapril, and the cardiovascular death or hospitalization for heart failure also. And as I said earlier, that the benefit starts pretty early. So these are the number of days. So you can see that at 7 days itself, as we saw in some of the previous slides, that at 7 days itself, you are getting benefit. And how much is the reduction? It is almost like 50%. So there is, in those patients who are not previously exposed to ACE inhibitor ARB, you get a very robust reduction in the combined endpoint of cardiovascular mortality and HHF. Now, de novo heart failure is an escalating challenge. So 43% proportion is the proportion of overall patients who have de novo HF, with rates ranging from 20% in North America and 79% in Southeast Asia. So basically, Asians have a relatively more incidence of de novo heart failure. And in one of the previous studies, 66% patients were newly diagnosed with heart failure. Now, ARNI keeps the de novo heart failure patients out of hospital and also improves mortality. So there is a significant lower incidence of composite of cardiovascular mortality and heart failure rehospitalization in these de novo heart failure patients using ARNI. So initiation of ARNI shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed de novo heart failure. This is a subgroup analysis, the transition study. The primary endpoint was the tolerability of treatment in proportion of patients who achieved the target dose. And secondary endpoint was this initiating shortly after hospitalization in newly diagnosed the proportion of patients who received and maintained any dose for about between 2 to 10 weeks, and any incidence of discontinuation of treatment. So what we find is that sacubitril valsartan or ARNI improves echocardiographic parameters in the de novo hospitalized HFrEF patients. So if you look at the main parameters, that means the ejection fraction being obviously the most important parameter. So you can see that the ejection fraction is significantly better. So the yellow bar, if you look at the percentage of patients who had an LVAF which increased more than 50%, that is significantly higher. If you look at the end diastolic dimension reduction, which is another important parameter of improvement in left ventricular left ventricular function, you can see that this is far better in the ARNI. So ARNI improved cardiac remodeling and pump function more effectively as compared to ACE inhibitor ARB in the de novo patients. Now, if you look at the HSTNT values, HSTNT also is to some extent indicates the myocardial damage or necrosis, and it is one of the markers for prognosis in heart failure. So what you find is that there is a significant reduction in the HSTNT concentration with ARNI in the de novo hospitalized patient with HFrEF. So the ARNI is definitely superior in that context. Now, more de novo than prior HFrEF patients achieved the target dose at week 10, that is 56 to 45%, with a relative risk ratio of 1.3, and fewer had SAEs and permanent treatment discontinuations. So, if you look at the comparison of de novo versus prior HFrEF, so this is not comparison of one drug or another, but the comparison of de novo versus the prior HFrEF or the chronic heart failure patients. And so you find that the de novo HFrEF was able to achieve target dose in more percentage of patients. So the transition study showed that first-line initiation of ARNI in de novo HFrEF alongside other guideline-directed therapies is quite feasible and is associated with better risk-benefit profile than in patients with chronic or prior HFrEF. So early intervention with ARNI should be considered to delay the progression in patients with de novo HFrEF. So what we now we have newly learned is that the treatment should be started as early as possible. It is quite feasible to start it, and it is quite well tolerated. So this is the most important aspect of it. If you look at the treatment algorithm of heart failure, so the ARNI is the preferred choice as the foundational therapy along with beta blocker and diuretics. ARNI is now also recommended in newly diagnosed and ACE inhibitor ARB9 patients. So these are the other sort of drugs that can be given. And so depending on various exclusion factor criteria or contraindications, you can start. Obviously, now SGLT2 inhibitor also has become one of the most important treatment. The important thing is that all the treatments are important. So today we are talking of ARNI, but it is not ARNI is the only treatment. So we need all the pillars of treating heart failure. And so the optimal GDMT should be achieved within 3 to 6 months of initial diagnosis of heart failure. Now, the ESC 2021 guideline recommends ARNI as the first line of therapy in hospitalized patients, and ARNI may be considered as first line of therapy instead of ACE inhibitor in patients. And I think that this aspect is pretty clear, that now we don't need to start with historical sequencing of treatment, but rather we should start with the most effective drug. So this is the 2022 guideline, AHA-ACC guideline for management of heart failure. Recommendations for renin-angiotensin system inhibition with ACE inhibitor, ARB or ARNI. So it's a 1A indication that in patients with HFrEF, use of ARNI is recommended to reduce morbidity and mortality. The patients with previous or current symptoms of HFrEF, ACE inhibitor for the same purpose when ARNI is not feasible. And when you both are not feasible, then only we should use the ARP. So if the patient is previously on ACE inhibitor, then you have to have a cooling off period or weaning period of 36 hours before initiation. Then you select the starting dose, which is usually in our patient scenario, if patient is taking equivalent of 10 milligram of enalapril. So we have to consider that every patient may not be taking enalapril or not taking valsartan, but this is an equivalent. So 10 milligram of enalapril or 160 milligram of valsartan. Then we start with 50 milligram or twice daily. If patient is taking a higher dose of enalapril or valsartan, then we start with 100 milligram twice daily. Now, at 2 weeks, if the patient is doing okay, if there is no issue of tolerability, then you increase the dose stepwise to a target of 200 milligram twice daily. When you are increasing the dose, you obviously have to monitor blood pressure. You have to look at the electrolytes, especially for hyperkalemia, and the renal function during this titration period. So we will obviously not talk about the other drug, but this is how you can switch from the ACE inhibitor to ARNI. So what are the reasons for failure to either tolerate ARNI or reasons for patients getting prevented from reaching the target dose? So you can see the most common reason for intolerance to ARNI is symptomatic hypertension, which is out of all the patients who are intolerant, one of the major reasons, that is in half of the patient, was symptomatic hypertension. The other was the worsening of eGFR, then was the hyperkalemia, and also the GI symptoms. So these are some of the major reasons why the patients are not able to tolerate ARNI. The reasons for failing to achieve the target dose, these were in 63 patients. Again, one of the most important reasons for not able to being able to escalate the treatment to optimal dose was symptomatic hypertension, and then other factors similar to the intolerance, that is worsening of eGFR, hyperkalemia, and the GI symptoms. The good part is that we have benefit in primary outcome measure even at lower doses. So because that if we say, especially in patients, Indian patients, if we say that our patients are not able to tolerate or not able to reach the target dose of 200 milligram twice a day, then are we really passing on the benefit? So if you look at the various doses, this is the 50 to 100% of target dose. This is the ideal dose. If you look at 50% of target dose, then what you find is that there is a benefit even when you are using a lower dose. So even when you are not using the 100% of target dose, even when it is between 50 to 100% or 50%, even then we are able to get the benefit. It is still superior to enalapril. Now, ARNI reduces the risk of cardiovascular mortality and HFrEF in HFrEF with low blood pressure also. So there is a 12% reduction in risk of cardiovascular death or HFrEF in HFrEF with low BP. So if you look at the event rate in 100 patient years, and you can see that there is a reduction even in those patients who have relatively lower blood pressure get benefit. Now, what is the risk of hypertension? Now, we know that the risk of hypertension is there, or the major reason for intolerance is also the hypertension. This is one of the issues with that. But if you look at the outcomes, that means if you look at the mortality after as a hypertension happens as an adverse event, and if you compare enalapril versus ARNI, then you find that the mortality actually is much lesser with ARNI as compared to the hypertensive episodes that happen with NLP. But we still have to be careful in terms of this hypertension, and older patients with lower blood pressures need more intense monitoring. So in spite of the incidence of hypertension, the risk of mortality with ARNI due to these adverse event incidences is still better. One of the common issue that one faces when we treat the patients with the ARNI is how to manage the hypotension in HFrEF patients. So one of the important thing is not to sort of stop or discontinue ARNI as a first step. So you know that one of the major issues is the volume, that is the volume depletion or salt depletion. So in those hypovolemic patients, the first step would be the diuretic should be de-escalated or down titrated. In fragile patients or elderly patients with low systolic blood pressure of 100 to 110, you can start with a lower dose so that the hypotension does not occur very commonly, and a slightly slower up titration can be done. In patients previously on low doses of ACE inhibitor or ARB, or naive to ACE inhibitor ARB, a lower starting dose or slower up titration is recommended. As with any other disease, you have to look at what are the other compounding factors. So obviously the patient is not just taking ARNI. So whether you should reduce the dosages or adjust the dosages of other drugs is also considered. So every drug or every pillar of heart failure treatment should ideally be present. So it is better not to withdraw one drug altogether. Rather, it may be a wise thing to reduce the other drugs also if required, but every type of drug should continue in the treatment of heart failure. So whenever there is a hypertension, it is better not to directly stop or withdraw ARNI, but it is first reduce diuretics, look at all the compounding factors that are present, and then you can also adjust other dosages. Now, this is a very interesting article which talks about whether the introduction of ARNI will reduce the need for device therapy in patients with HFrEF. So we know that devices are, especially in a country like India, the cost is a major factor. And therefore, if we can reduce the need for devices, not only just in terms of procedure, but in terms of a significant cost, then it is a very important thing. So we know that there are recommendations for an implantable defibrillator in patients who need secondary prevention. Those patients who have had a previous ventricular arrhythmia which caused a hemodynamic instability, and they are expected to survive for more than 1 year with good functional status. The other indication for ICDs is primary prevention, where you have a risk of sudden death in patients who are in NYHA class 2 to 4 and LVF of less than 35% in spite of 3 months of optimized medical treatment. So, and they are of course expected to survive. So ischemic heart disease should ideally be, at least you have to wait for 40 days, and diabetic cardiomyopathy. So if the patient has symptomatic HFrEF, then you treat all reversible causes, optimal medical therapy, ARNI to replace ACE inhibitor ARB. Now, the gap in the evidence is that long-term data on tolerability and compliance of ARNI in real-world scenarios is not yet available. So this is for the step 1. But what do you do in those patients for CRT? So these are the criteria for CRT. That means LBBB of more than 120 milliseconds, QRS width, non-LBBB, QRS width of more than 150. Now, there is no data on significant positive benefits of CRT or ICD when used over and above ARNI. That means if the patient is already on ARNI, then we don't know whether the CRT produces an additional benefit, because some of the trials were done before that. We know that CRT non-responders are 30%, and two important this thing are frequent premature beats or ventricular arrhythmias and progression of heart failure. Now we know that the progression of heart failure can be affected by ARNI by reversing the cardiac or reducing cardiac remodeling, and therefore the heart function parameters can actually improve. It also decreases ventricular premature beats and improves the biventricular pacing, and therefore actually the need for CRT, or in those so-called non-responders, there may be actually a benefit given by ARNI. So this is the data of clinical presentation in hospital and 90-day outcomes of heart failure from the Trivandrum Heart Failure Registry. So you can see here the cumulative mortality. So at hospitalization and at discharge, if you look at the outcomes, if the patient was treated with guideline-based treatment, then the outcome was definitely much better. That is at hospitalization or at discharge. So which shows that guideline-directed medical therapy is very important. Now, what is the prevalence of diabetes in heart failure? So these are all the trials of heart failure. And if you look at the diabetic prevalence on an average, the overall data shows that is in the tune of 30%. Now, if you look at the other corollary of it, what is the incidence of HFrEF in diabetes? So it is in diabetic patient, the heart failure is present in about 10 to 30%. So there is some kind of two-way relationship between that. Now, the ARNI reduces the cardiovascular mortality and HFrEF and the quality of life irrespective of glycemic status. So what are we trying to say here? That whether the patient is normoglycemic, whether he is a pre-diabetic, whether the patient is undiagnosed of diabetes or a clear diabetes. So in any of these diabetic status, from normoglycemia to frank diabetes, you can see that there is a risk reduction in cardiovascular mortality, HFrEF, all-cause mortality, and of course the symptomatic benefit in the Kansas City questionnaire. So there is a 20% reduction in cardiovascular death and 20% reduction in heart failure hospitalization. So this is irrespective of that. Now, what is also more interesting is that the changes in the HbA1c, if you look at the patients treated with enalapril versus ARNI, then you have actually a better glycemic control. So there is a somewhat of a contribution by ARNI to even glycemic control. So compared to patients treated with enalapril, patient treated with ARNI had a better reduction of HbA1c. Now, if you look at the effects of ARNI on insulin initiations and oral antidiabetic drugs, the new use of insulin was reduced by ARNI 29% more as compared to enalapril, and fewer patients were started on OHA therapy with ARNI. So basically, we saw that HbA1c reduction or control is better in patients treated with ARNI as compared to enalapril, and the need for insulin is prevented in larger number of patients, and also the oral hypoglycemic agents. It is said that HFrEF starts at the heart and then goes elsewhere. That means it affects other systems, whereas HFpEF starts elsewhere. That means starts in other systems and ends in the heart. So these are all the various factors, the cardiac factors, the pulmonary, the hepatic, the renal, the obesity, the musculoskeletal. And so all these factors, so metabolic stress, aging, remodeling, all these would lead to HFpEF. So the HFpEF is pathophysiologically somewhat different. Now, till now, if you look at the various trials done with perindopril, candacertin, irbesartan, then they were largely unsuccessful or failed to reduce, especially in the major endpoints like mortality. There was a somewhat of a better result with spironolactone in the TopCat trial. So probably to some extent, mineralocorticoid receptor antagonist of spironolactone had some marginal benefit, but not very significant. The observational studies suggest similar clinical outcomes. That means basically what we're trying to say is that the outcomes are not different for HFrEF and HFpEF. But now we have very good treatments for HFrEF. But as we saw in the earlier slide, we don't have very good treatments for HFpEF. That means all the previous trials have failed to sort of show significant benefit in that. If you look at the Paramount trial results, then we are not talking of mortality, but if you look at the other surrogate endpoints, so if you look at the NT-proBNP, then you can see that compared to valsartan, the ARNI produced a better reduction in patients with HFpEF. The left atrial size, which is an indicator of the diastolic dysfunction or one of the other markers of presence of HFpEF, you can see that compared to valsartan at 12 and 36 weeks, the decrease in left atrial size was much better with ARNI. If you look at the improvement in the NYHA class, again, that was better with ARNI as compared to valsartan. So basically, if you look at the soft endpoints, then HFpEF patients also get benefit of ARNI. This is the Paragon heart failure trial, which is a randomized double-blind active comparator trial comparing the ARNI with valsartan to look at the total HFpEF and cardiovascular mortality. The key inclusion-exclusion criteria were the patients with EF of more than 45%, again, NYHA class 2 to 4, those having structural heart disease had to have elevated natriuretic peptides without any acute decompensated decompensation event. Now, the primary endpoint again was similar, that is cardiovascular mortality and HHF. After the run-in period, the patients were randomized to the ARNI at 200 milligram twice a day, that is the target dose, and valsartan 160 milligram twice a day. And secondary endpoints also included improvement in symptom status in terms of NYHA class, the Kansas City score, the time to first occurrence of worsening renal function, and the all-cause mortality. Now, if you look at the heart failure hospitalizations, then you clearly can see that compared to valsartan, in these patients, the ARNI did better. So the cumulative events of heart hospitalization were reduced. If you look at the cardiovascular mortality, that also is reduced, but not statistically significant. So there is, it failed to achieve a very significant reduction in mortality. But at least there was a reduction in hospitalization for heart failure, which was sort of fairly statistically significant. Now, here is one of the most important slide in terms of the crux of the issues with heart failure with preserved ejection fraction. Now, let's sort of briefly look at the gender related factor. That means there was a benefit in female gender, but not as much with male gender. But now let's concentrate on that dividing line of ejection fraction, which was 57%. So if you look at those patients who had the ejection fraction at or below 57%, then there was a benefit in primary endpoint. Whereas if they had this absolute normal or supernormal ejection fraction of more than 57%, then it sort of did not have as much benefit. So this is a very interesting thing, because one thing we have learned is that in those patients who have even mildly reduced ejection fraction, probably there will be a benefit, but we still don't know about those who have this supernormal. This is again the relation to ejection fraction in terms of quartiles, and you can see that the benefit is present when it is less than 50%. That means for sake of definition, if you consider more than 40 or 45%, then in that mildly reduced ejection fraction, also you get benefit. In minimally reduced, you get benefit. But when you go to this normal and super normal, then you don't find as much benefit in terms of the benefit in primary endpoint. So the EF cutoff for benefit was 57%. Now, if you look at the HHF and cardiovascular mortality by LVEF across spectrum, we are not talking of HFpEF now, but we are talking of all the this thing. Then except for those with 60% or more, that means real normal, super normal ejection fraction, all other ejection fractions, that means anything from mildly reduced to very severely reduced, that means even less than 25%, then there was a clear-cut benefit as compared to the comparator. So we know that any range of ejection fraction, except the super normal ejection fraction, gets benefit. Now, can we start ARNI in patients with HFpEF, that is in patients between 40 and 57%? So the recommendation for HFpEF now include in those patients who are more than 50%, diuretics is the only treatment which is recommended, which reduces symptoms. There is, of course, there is nothing that reduces mortality. SGLT2 inhibitors now are recommended in 2A because there is a new evidence that they may to some extent help better. ARNI is also now included, but in 2B, and then of course you have MRAs and ARBs in 2B. So this is kind of a new opening in HFpEF that we can use it in certain types of patients of HFpEF. Now, what are the adverse effects? Now, if you look at the incidence of angioedema, that was slightly better, more, but not really very significantly higher. Interestingly, if you look at the impaired renal function, then actually there was less incidence of impairment of renal function as compared to the enalapril comparator. So actually, it was better for preservation of renal function. The only problem, as we saw earlier also, is that hypotension is relatively more with ARNI as compared to enalapril. The incidence of hyperkalemia, contrary to what one would think, was actually lesser. The incidence of cough was also lesser as compared to enalapril. So, except the incidence of hypotension, there was no other increase. Actually, there was a decrease in side effects. Now, again, if you look at the renal safety and the hyperkalemia, then the risk of hyperkalemia associated with the use of MRAs was lower. That we know that when you treat the patient with MRAs, there is a risk of hyperkalemia. So, in those patients treated with ARNI versus those patients treated with enalapril, there was a less increase in serum potassium level, and there was a lesser incidence of severe hyperkalemia. So the amount of increase in potassium was lesser with ARNI, and also the incidence of severe hyperkalemia was actually reduced. So what are the contraindications? That if the person is already taking ACE inhibitor, you should wait for 36 hours after withdrawing it. If patient has a history of angioedema with or without the ACE inhibitor previously, not indicated in pregnancy and lactation, there is no data about it. If in severe hepatic impairment, of course, it is not to be used. Concomitant use of aliskiren and any other hypersensitivity, especially to AR. The caution is about the renal impairment. So in the renal impairment is very mild to moderate. That means the eGFR of more than 30. There is no dose adjustment required. But when it is less than 30, then you need to start with a lower dose. Similarly, in hepatic impairment, in the mild hepatic impairment, no dose adjustment required. But in moderate hepatic impairment, you need to adjust the dose. Renal artery stenosis and systolic blood pressure of less than 100. So these are the patients and the volume depleted patients where you have to be cautious to avoid any incidents of symptomatic hypertension. What are the drug interaction? Any patients who are taking ACE inhibitor or had previous angioedema with ACE inhibitor should not have it. Aliskiren we saw earlier. Now, we saw that potassium-sparing diuretics has a slightly higher incidence of hyperkalemia, but actually there is not much of an issue with ARNI as if you compare it with valsartan. The NSAIDs, if the patient is taking, one has to make sure that the renal functions are tested, and any birth control pills that contain drospirenone should be avoided. How do we manage hyperkalemia? The patient should be on low potassium diet. Loop diuretic will help in reducing the potassium. K-bind in emergency situation combined with aspirin nebulizer. The old is gold treatment, that is glucose insulin infusion in difficult situations, and there may be a other option available in future. And this is a very important issue because now after treating with ARNI, we know that the patient's ejection fraction actually improves, the patient's end diastolic dimensions and systolic dimensions improve. And so the patient is symptomatically better. The patient has got better LV ejection fraction and dimension parameters. And so the patient is kind of now in a recovered heart failure stage. The issue is that now should we stop or withdraw the treatment with ARNI? Now, the most important thing here is those patients who discontinued, that you can see here, the treatment, there was a significantly increased hazard. So ARNI withdrawal in patients with HFrEF was independently associated with increased all-cause mortality, and patients who continued with the ARNI presented an improved functional class EF and NT-proBNP level. So the withdrawal of ARNI can actually put you back in the heart failure vicious cycle. That means your ejection fraction can start going down. But more importantly, as this data shows, that withdrawal of ARNI can actually lead to increased all-cause mortality. So we know that the patients actually are not necessarily always in the same category. That means a HFpEF can move to medium range to reduced. From reduced, it can recover to mid-range or even preserved ejection fraction. So what are the guidelines suggesting improved ejection fraction? So in patients with heart failure with improved ejection fraction after treatment, the GDMT should be continued to prevent the relapse of heart failure and left ventricular dysfunction, even when the patient has become asymptomatic. So this is a very important thing because our patients also tend to sort of by themselves stop the drug because they think that they're absolutely now fine, but they have to be told specifically that this withdrawal of drug can lead to the prognosis getting worse, and they will sort of have increased incidence of heart failure, admissions for heart failure, and also their ejection fraction will start going down. So ARNI is the molecule of century and is very indispensable in patients with heart failure. It improves the symptom status, it improves the combined endpoint of mortality and heart failure, reduces heart failure admissions, improves the LV ejection fraction and other dimension parameters. The important thing is that it should be started as early as possible in the decompensated and de novo heart failure without waiting for the so-called chronic patients or stable patients. An ARNI should be used in all patients with HFpEF up to 57%, for which we have benefit. Thank you.